So we're coming up to 10 o'clock where we'll start. I think I've got Suzy is here as the program manager, and I thought I'd introduce you to her and welcome. Suzy, is this system working for you, and are you able to unmute and things like that?
Good morning, Andrew.
Oh, hi, Suzy. We've not met, and it's really nice to meet you.
See you and everybody. Yeah. Thank you.
Yeah, tell us about yourself, Suzy. How long have you worked at the NIHR?
Absolutely. So I'm the Senior Research Manager for the application and funding part of the HSDR programme. So I've worked in the programme for about 10 years in various roles, started off as a researcher, then a research manager, and in more recent years took over the Senior Research Manager role. So my team, there's 6 of us, including myself. We are based in one of the NIHR coordinating centres, and ours is the one that's in Southampton. So we're hosted by the University of Southampton. So my team looks after application and funding, which is pretty much what it says on the tin. We look after the calls from the point at which they are approved to be advertised by the Department of Health. So the point at which you see them up on the website, all the time that the calls are open. So we're there to respond to queries. We then take the applications that are submitted through the assessment process and onto committee. And then we manage those committee meetings, all the feedback. And we hand over the projects at the point at which they are approved for funding onto our monitoring team. So that's me and my role in the programme.
That's terrific. What's the best bit about your job?
The bit I really like is actually talking to applicants, which I get to do less in this particular, in my sort of more senior role as a research manager, and in pre-COVID days when we had phone lines. What I really enjoyed was people phoning up and just wanting to talk through their ideas. And quite often they had an idea that would be of interest to the programme, but they just needed to slightly change the perspective of it to fit more firmly within the remit and to have the best chance of funding. So that was a bit I really enjoy, something I don't get to do so much. But yeah, talking to people and hearing about their enthusiasm and how they want to contribute to making our health and social care services better. That's great.
Really glad you said that, because this is, as I say, I've not met you before, but I've not yet met a program manager that says, I hate speaking to our clients, our applicants.
No,
every single person that I've met wants to support. And I think this spirit of openness and support that's out there is something that really does feel quite unique and encouraging. And it's why the NIHR has such a great impact, because it's the people. And so I thank you really for all of the work you do, and I'm really looking forward to this morning. We've just got a couple of minutes. We said we'd start this next section at 10 o'clock. So we'll just take a moment's breath. So hopefully you have, I think you have some slides that you're going to
yes, I do.
Should we put those up on the screen?
Sharing,
just check that works.
We're normally on Teams these days rather than Zoom, but we'll give it a go.
And for the participants, I might just mention that you can probably see there's a little recording button in the corner, and if there are questions we don't get to live, we will deal with them by email afterwards. That's perfect, Suzy. That's working. Great. Just spot on.
Yeah, I'll wait for the nod from you, Andrew.
Oh, well, I feel like that. Do you remember when the TV used to have a test card with a little clock that counted down? We're in that last 60 seconds, and then we'll just go for it on time. But thanks again for being here this morning, and I'm really looking forward to this. Okay, over to you, Suzy. Welcome to this webinar about the funding programme.
Thank you very much. And it's great to see so many people logged into this webinar and interested in the programme. So welcome to everybody, and thank you to listening to me this morning. As I said, I've worked with the programme for about 10 years, and so my job today is really to share with you sort of my knowledge of how we operate, so what it is the programme is looking for within applications. I've tried to pitch this at the level of kind of that covers all bases, so you might not have really sort of met the programme before, as it were. So I'm going to start right from the beginning in terms of remit, take you through our processes and timelines, because things have changed a little bit in the last couple of years. So if you've sort of visited funding opportunities in the past or applied in the past, it might be good just to sort of listen out for where things have changed. Not a lot, but hopefully for the better, to make things a little bit quicker, more efficient and more joined up. So, okay. There we go. So today, as I said, I want to start by talking about the remit. So what's in, what's out. I'd like to talk quite a lot about social care, because that's now very much part of the programme, and sort of describe the differences between us and the other programmes that we share a similar remit with, or areas where we overlap. And then to sort of bring that a little bit to life, give you some examples of studies that we have funded in the last few months to show you the breadth of what the programme is interested in, the type of calls that we put out. And then we're going to talk through our processes and the timelines, talk about what it is that is looked for at each stage to give you an idea about how to make a good application and give your application the best chance of success. And then I'd like to talk about the kind of current areas of interest. So those sort of additional key factors that the committees look for in your applications that kind of are over and above, or sort of areas of particular interest that I think it'd be helpful for you to know that that's a sort of key interest for the programme, and for you to try and build those into applications should you choose to submit to us. So, whoops, away. So starting with our remit statement. So this is the statement up on the website. Health and Social Care Delivery Research Programme aims to produce rigorous and relevant evidence to improve the quality, accessibility and organisation of health and social care services. So to unpick that a little bit, the name itself has changed. In 2021, we expanded the remit to make social care absolutely fundable through the programme. Before that, it was an element which could be involved within applications, but not as sort of a standalone area of focus. So 2021, very quietly, we changed from being the Health Services and Delivery Research Programme to the Health and Social Care Delivery Research Programme. So we kept the initials HSDR, but so some sort of on things that haven't been updated, you may still see the programme referred to as HS and DR. The key thing to know about the programme, if you're new to looking at us for funding, is that we only fund services, so not individual treatments or health technologies. So the focus isn't around clinical effectiveness. It's a much bigger view of services and how they are organised. And then the point around rigorous and relevant evidence. So all of the research itself, ideally, we're hoping will have actionable findings. So the scale and the rigour of the research needs to produce national learning that has direct utility. Where there are very large research gaps, we may call for research that's a little bit more interim, but for most studies, and especially coming through researcher-led, we would be looking for the studies to produce something which is of immediate benefit for health and social care services. So to give you an idea of what we will and won't fund, a typical HS&DR study these days is about 36 months long, around 800K, usually mixed methods and tackling health inequalities. So we do fund a whole range from I think the smallest I've known was a systematic review update that was about 60,000, I think, up to some very, very large national evaluations. I think the biggest of which is about 2.6 million. So that's our range, but most studies come into this sort of 3 years, 800K sort of bracket, to give you an idea. So what that means in terms of the sort of studies that the programme is looking to fund is need and importance is the first key hurdle that any study has to get past. So that is the number one thing that your study, your focus of your research is going to have to look to address. So the research has to be needed, so to address a clear evidence gap, and there has to be potential there. And not only that, but the actual question within that research gap needs to be important to services or service users. So as I said before, we're looking for quite large studies. So there's the findings need to be generalizable. So it's sort of national level learning. That means that the studies themselves are multi-site, large scale. They have to be theoretically informed. By evidence-based, I mean building on research that has already been published, or at least is in the pipeline, so not starting from new, and very much stakeholder engaged. So we are really keen to see the key stakeholders involved right from the beginning to shape that research and to make sure it's fully grounded and the outputs are going to be really useful. So we're looking for ambitious multi-stage research, and all of the findings need to be synthesized at the end, so they can't be open-ended research as some other programs do fund. So, the flip side of that, of course, in terms of what we won't fund, are small-scale local studies. They're going to be much more suited to other programs such as research for patient benefit. We take PPI and inclusivity very seriously. So if those aspects haven't been considered, then your research is not going to be fundable. We cannot fund fellowships within the study itself or as standalone fellowships. That's something you would apply to the NIHR Academy for. We can't fund databases. I put feasibility and pilot studies on this list of things we won't fund. We won't fund them where there is no learning from that research beyond sort of acceptability and recruitment. So if the purpose of the feasibility or pilot study is just to inform whether a larger evaluation could be performed, then we wouldn't fund it. But if the feasibility study goes beyond that, in that there's some learning around acceptability, around effectiveness, around barriers, those sorts of things, that if there is some learning from it, then it would be fundable. And as I said before, we don't fund programs or ongoing work, so they need to be discrete projects which the findings are synthesized at the end. So to compare us with the other NIHR programs that we share sort of a similar remit with, or at least overlap, if we start looking first at HSDR, the first column. So we don't have any funding limits per application usually. Very occasionally, there will be a call which does have a limit. I think in my 10 years, I've only known one commissioned call where that was the case. And for sort of an open call that's looking for research into an area, in addition to commissioned calls, we do also commission rapid evaluation teams, and they do have a set budget. Those contracts only come up every sort of 3 to 5 years. So the vast majority of our commission calls and all of our researcher-led, there is no funding limit per application, and there is no funding limit per year. Having said that, we do have an annual budget agreed by the Department of Health, but so far we've been fortunate in being able to fund everything that the committee has recommended. In the 10 years I've been doing this, I think I've only known one round where there was one application. Well, there was one round where the committee funded a couple more applications than the department was comfortable with, and they got rolled over to the next committee, and then their funding decision was made there. So, as I say, we're very fortunate in being able to fund everything. I would like to say that is appropriate to the remit of the programme and will address a need, and produce evidence which is useful. We have also, in the last couple of years, shifted our committee structure. So we have moved from having prioritisation committees, which looked at our stage 1 applications, and then the stage 2 applications went on to be looked at by a funding committee. We have merged those committees together and restructured things so that we are now able to offer 6 call closes per year. So that means that there should be 6 researcher-led closes every year. There's usually 2 or 3 commission calls alongside each of those dates. And in addition, there will be, on occasion, some ad hoc commission calls when there's urgent need for research. So that's more opportunities than all the other programmes tend to offer. So in real terms, that means you could apply to our programme every other month. If there's very, very high capacity for our commission calls, then it may be that we roll over one of our researcher-led calls, because that's sort of our escape valve, if you like, when there's too much capacity going into the committees. But the general rule is that we now operate 6 researcher-led per year, plus, as I say, 2 or 3 usually, sometimes more commission calls per round. And what that will mean is that there's usually 2 researcher-led calls open at any one time. So you do have options of shorter and longer timelines to come into the programme. In terms of sort of contracting organisation, it can be universities, NHS bodies, anybody which is able to work under the policy framework for the research governance. So we're less constricted than perhaps our smaller cousins with a research patient benefit programme in terms of not being limited to the NHS. So that sort of reflects our larger scale approach to the research that we're looking to fund. And in general, we can accept applications across from contracting organisations across the UK. The only exception to that is our commissioned calls we cannot accept from Scotland. Very rarely there's special permission from Department of Health for that to be waived, but in general that's the case simply because Scotland does not contribute to that part of our funding. But researcher-led is always open to Scottish teams. So to give you an idea of the sort of research that the programme funds, these are all the studies which were funded November, December last year. And I just wanted to give you sort of a snapshot of the sort of variety of studies, the different calls that are put up, sort of numbers, sizes. So I'm not going to read through the whole lot, it's there in front of you. But I wanted to point out, you can see we've got several researcher-led calls. The evaluating high volume, low complexity surgical hubs model and the evaluating implementation of transforming children and young people's mental health provision green paper, bit of a long call. Those 2 calls were for national evaluations of those 2 particular initiatives. And so those were head-to-head calls. So that's not unusual. There's probably 1 or 2 of those per year, where it's usually NHS England has requested an independent evaluation of how something's being rolled out, or maybe evaluation to go alongside in order to inform scale up. So those would have been head-to-head calls. Where just 1 application was funded. Usually for our commission calls, there is quite a broad range of research that's being looked for. So there's far less limits, and the applications are not usually considered to be head-to-head. Also up there, so that was true of the net zero calls. So they're both sustainability type focus. And then we've got a fast track call there. So we do offer that as a funding stream into the programme. That's where you can submit a straight to stage 2 application. So instead of going through the normal 2 stages, you come in straight to stage 2. And that's there for cases where the applicants can convince the programme that the research needs to be started rapidly. So in this case, it was to evaluate, investigate the implementation of mobile stroke units. So something that various regions were starting to invest in, but the evidence base wasn't very strong for. So as a rule, that straight to stage 2 route is quite risky because applicants don't get the benefit of feedback from the committee at stage 1. It doesn't have a very good success rate, but just to highlight it is there. And it's really, in some ways, it's a little bit historical. All the programs offer it, but now that we've moved to a much more open committee structure in that we can offer 6 call closes per year rather than 3, our timelines are shorter and more flexible. So often there's little benefit to going through that fast track route. So we would recommend that unless something is very urgent and you've timed it such that you've just missed a call close, we would recommend going through this 2-stage route. And then on the bottom of that list, you can see the social care rapid evaluation research team. So as I mentioned before, the programme funds several teams. So we have evidence synthesis teams, rapid service evaluation teams, and now a rapid social care team. And we're also in the process of funding a tech-enabled home monitoring interventions team. So these are sort of in-house teams that when topics and research is needed, requests are made to the programme from our national partners, those are diverted straight to these teams. So they're usually quite small, quick projects, but they can be very variable in size so that they can start straight away. And they've been very successful across the range. Those contracts, as I said, sort of come up every 3 to 5 years, and they have a fixed budget. So that's just to give you sort of the breadth of the sort of costs and lengths and type of studies. And just to sort of note, all of these studies are all mixed methods. None of them are trials. So that's very much typical. We do very occasionally see trials, but due to the complexity of services, a trial approach isn't usually the most effective and efficient way of addressing an issue. So I just wanted to plug a little bit social care research through the programme, as this is something that has been very much strengthened, as I said, through the last few years since the remit has changed to fully facilitate funding of social care studies. So I wanted to just describe a few of those social care commission calls that we have put out and the types of research that has been funded through those. So the first one of these was adult social care partnerships. So these look to set up partnerships and build capacity of research and using research for evidence-based practice across social care, as that was quite a gap in practice at that time and something the programme was really looking to support and develop. So we funded 5 teams based across various regions of England, and those are up and running. And then other social care calls that are sitting more across health and social care, with the exception of the social care team. We did a joint call with the What Works with Children's Social Care, jointly funding research into children and young people who may be in care as well, family group conferencing. That was taking an American intervention and making it work within the UK context for children and adults often vulnerable within the care system. And then more recently, health and social care workforce, looking at leadership, skill mix and flexible working, and well-being across health and social care. So I just wanted to flag that it is very much a core interest of the programme alongside healthcare as well. And as we all know, integrated care is very much the way our systems are working. So lots of applications will have an element of social care in. So to move on to think about the actual assessment process and the timelines that the programme is now operating under, to give you an idea about the sort of operational side of things, because as I say, that has changed a little bit in the last couple of years. So we now operate these 6 call closes, and across the year, this is now in a sort of steady state We've been doing this for a couple of years. There was a sort of transition phase, end of 20 into 21. And we now seem to be quite settled into this pattern. It's working well. So an application will be seen by the same committee at stage 1 and stage 2. So you won't sort of hop between meetings. This is the pattern that fits with the timeline of how much you as applicants need to write up your application between stages and for us to undergo external review and all those sorts of things that I'll talk about in more detail. But I wanted to give you the general pattern of the year to stress the point that there are lots of opportunities. If you're not quite ready for one when you see it advertised, there will be another one coming along very soon. And so this is our sort of general way of working. I put in the start dates that are typical for those timelines. Very occasionally you'll see a quicker start date for a commissioned call. That's when there's something is needed to be up and running. So we do have a bit of flexibility about the contracting end of the process. But on normal practice, sort of routine practice, those are the dates and the timelines that work through. So against every call advert that we put up on the website, there will be a timeline that's matches that call. So you should be able to see exactly when each stage is happening, gives you a full idea of the timeline for that call and when you expect to have the final funding decisions. So in general, for commission calls, they will be open for a minimum of 8 weeks. The research-led tends to go back to back. One round closes, the next one will open. There'll be about a week, possibly 2, but between that open and close, just to avoid any confusion of people who are we're going to sort of submit to that one that's just closed. So usually you will see 2 calls open at any one time. And so each of our committee meetings will see both researcher-led and commissioned calls. So this slide, I apologise, some of it's made it quite tiny, you might need to zoom in. This just gives you an overview of the entire process, the sort of standard process, 2 stages that all applications will go through. And just as an example to sort of map that through in terms of months and when you hear outcomes and things. This is using the example of one of our current calls, which is the Children and Young People's Weight Loss Clinics call. But this applies to everything that's going to be closing in our mid-March call close, so heading towards the May meeting. So for a commission call, there may be a webinar available to support the call that will be advertised on the application. My team is always open to receiving remit queries by email. And for researcher-led, we very much also welcome sort of a 1-page summary if you've got an idea for research and you want feedback. So that's kind of the best way to contact us these days, to do it through that. You can either do that through email to HSDR info or put in a ticket through Realms. So that's the online application system. So when you've opened an application form or you go into a call, at least you'll be able to send a ticket to us. You know, those are kind of monitored every day or through the day, and we will respond through the system. And if it's helpful, how we work at the moment, we're all working from home, just a couple of days in the office. We don't have a phone line anymore. We have limited direct phone lines. We tend to work by getting back in touch and arranging a call on Teams is how things tend to work. So we find it helpful if you can email in information first, and then we can come back to you. And if it's helpful to talk through something, then we can arrange that call and do that. So we're here to support you while adverts for calls are open, research-led or commissioned. When the call close comes around, you submit the application, and then it'll go through a remit check. So that's a first triage step, and I'll talk a little bit more about that in a moment. If it gets through remit and competitiveness, your application will go to a funding committee. So in this case, the May funding committee, where the primary criteria around need and importance, feasibility If you're shortlisted, you'd get feedback and invited to invite a stage 2 application, and you'd get 8 weeks writing time to write up that stage 2 application. You then submit the form back to us. We send that then out for external review. We have also streamlined our external review process. So we used to go out for, on average, about 5 external reviewers per application. We're now using the expertise that we have within our committee to provide a lot of the methodological review. So you'll still get reviews usually about the subject matter experts, but you're far less likely to receive a review based on the methods in an application. So once they've been to review, we then send you any questions that the reviewers have raised. So if you've applied to us in the past several years ago and applied to us now, you may be surprised that you only possibly get 2 or 3 reviews. But that is the reason behind this. So you get a chance to respond to any questions raised by the reviewers, and then all of that paperwork goes to our committee members, and they discuss that and vote on your application at a meeting. So a stage 2 application form is far bigger than the stage 1 application form. So you've got room to put in lots of detail about the science and methods. So that is what is primarily looked at that second stage. Coming out of that meeting, the committee will make a funding recommendation or decline it, or invite you to come back and have a second go. Most applications that are supported for funding go through a process called fund with changes. So that's when you are given 4 weeks to do any final revisions that the committee has requested. Those changes are then agreed by the programme director, and then at that point you'd go on into contracting. So that's a kind of overview that all of our applications that go through a standard 2-stage process will go through in terms of steps. So we think about sort of making a good application and what's required at each of those steps. And I'm mindful I'm running out of time, so I'm very happy to share all these slides, but I'm going to skim through this bit as quickly as I can. So all of the information around calls is up there on the website. So number 1 rule, read all of that before you start. Now, when it comes to remit and competitiveness, if it's a commission call, you still need to tell us how the proposal meets the requirements of the call. It may feel like you're stating the obvious, but it's really important to state that clearly. And then this first step is looking to see whether the application's in remit and then whether it's a good enough standard to go forward to committee. So the issues that are screened for in this first step are good value for money, whether it's a reasonable approach in terms of scale and design, you've got the right people involved, whether you've got the right stakeholders that you've talked to and are involved in the study going forward, whether you've got strong PPI, whether it builds on existing work or addresses a gap, and to make sure it doesn't overlap on any existing research. So any one of those factors, if it's missing or way off the mark, is enough for you to be rejected at that point. You would get feedback, and if it was a good idea, we'd invite you to come back round and have another go. But those are all the issues that you need to be making sure you've got right to get through that first step. We've raised the bar slightly at Remit and Questioners because we found, whereas before we were very inclusive, those weaker applications never got beyond the first stage. And therefore, in order to get more high quality research through and to give people a chance to have a second attempt, which we feel is less burden on an applicant than carrying on through and then being rejected further down the road, we have raised the bar slightly at this stage. Oops. So stage 1 criteria is very much around need and importance of the research to the NHS and social care. So that is what your application will be judged on to start with. Is the research needed? i.e. does it answer a research need, a gap? Is it important? Is it something that evidence users are going to want to know about? And then you need to think about the feasibility. So very much thinking inside a very stretched health and social care system, has the way you've designed your research can that actually be delivered? If you've got loads and loads of interviews, you're taking GPs away from their practice. If you're, you know, trying to follow midwives 24/7, something like that, those are issues which are going to be picked up and questioned by the committee. And then there's a third point at stage one is around the science of the study. So at stage one, the committee is very much looking for fixable flaws. So they want to give feedback, they want to support the study. And so if the foundation blocks are there, the team will receive feedback on how to strengthen the application to make it even better at stage two. So, as I said, those are all the issues that are going to be looked for. I'll just pass on to that. When we get to stage two, the stage two form is much, much bigger. So you've got lots of opportunity to provide all the detail around the scientific methods, provide a budget, all around the timescales, more detail around your team, and you'll have an opportunity to respond to that feedback that the committee is given at stage one, as well as respond to everything that the reviewers have raised as queries as well. So these are the criteria that the committee are using for stage two, and it's more about the detail about how that research can be delivered around the methods of science. So I won't go into this detail because I'm happy to share these slides, but as I said, you have got capacity to put all of that detail into your form. So we really recommend that you use that opportunity, and in particular, respond to the feedback that the committee has suggested, because the committees have about 20-25 people, highly experienced researchers and people who work in the service. All of our feedback, we try to be very constructive. So we really recommend that you do take it on board, or if you do feel that they've got it wrong, misunderstood, or you have an alternative view, then it's important that you do state that case. Likewise, with external review, it's your opportunity to provide some extra clarity and detail. The committee will look at all of those responses as part of their decision making. So you have got that extra detail, extra space rather, in the second stage. There's a 20-page upload for all of it. So we do suggest that you think about making your application future-proof. Tell us all about the expertise in the team. Think about risk mitigation. Think about inclusion and dissemination. So finally, all of those things are sort of described in our guidance notes on the information on the website. But I just wanted to highlight these issues to sort of end up my talk, because these are the key things that the committee are looking for to be there embedded in your research. So naturally, your research needs to be designed and planned appropriately, all of those methods in place. But it's absolutely key that you have undertaken stakeholder engagement. So you've talked to those people who are going to be using the evidence or working on the front line, and you've got them involved in your application. They can be there as co-applicants or as collaborators or sit on an advisory group, but the committee will be looking to see that you've got that voice, and so that your research that you are aiming to deliver is absolutely needed and matches the needs of those people. And then EDI, so equality, diversity and inclusion, is a real key interest at the moment, and we're trying to embed it throughout everything we do. So to stress this, when it comes to our committee meetings at stage two, one of the committee members who presents your application to the rest of the committee, they will be focusing on EDI within the application. So it's an absolutely core interest. And we have EDI observers who comment on how the programme is running and point out areas that we should be challenging. So, for example, routine data sets. A couple of years ago, the programme would have been very, very much welcoming use of routine data, very efficient, very efficient study design. However, if we now consider what are those routine data sets based on, so if we're thinking about GP data sets, there's a whole sector of society that doesn't engage with GPs. So you're automatically excluding those patients by just focusing on a routine data set. It's that sort of thing. So it's challenging assumptions, making sure you're actually involving as broad a sector as people as possible, and make sure that you're researching with people, not on people. And then sort of along the same lines, PPI, public patient involvement, has been key to the programme for as long as I have worked with it. We have public members on our committees. Every single application is reviewed by a public external reviewer where we can find somebody with lived experience. And then we have 4 public committee members on our committees who comment on every single application. So that's quite unique across the programmes and demonstrates how important PPI is as shaping studies and making sure that we're answering real world problems for patients and families and service users. And then finally, on impact, this is going to be growing ever stronger as a focus for the programme. Your dissemination strategy and your the products that you're producing from your research are really, really important. It's no longer satisfactory to say you're going to do a final report, maybe do a conference. The committee will be looking for far more a range of products for sort of service managers, commissioners, but also for public and patient users. So different formats. They're very, very open to much more creative and engaging approach to dissemination. And then my last slide is just about capacity building. So to say we very much welcome new lead applicants. So on the form now, you can officially put on joint lead applicants. So very much welcome that first lead applicant being perhaps a newer, younger researcher with less experience and supported by somebody with more experience, or somebody on the team needs to be their mentor. So we would be looking for time and money to be costed in for that mentorship. And we would also welcome spreading out research activity across the country into areas where it's really needed, because that usually does align where there are less research active organisations. So we really welcome more established teams and organisations partnering with those less active organisations. That's now a line that's been specified in our current Diabetes UK joint funding call. And we're going to see the response of that, but I think it's something that's going to be built into all our calls going forward. So top tips, I won't run through that now. That kind of sums up everything that I've said. And just to say, always happy to answer queries through our email, through Teams. We can book in calls with you. And thank you very much. That's me. Sorry to overrun a little bit, but thank you. I'll stop sharing.
Suzy, thank you so much. That was so terrifically helpful and clear, and I have no doubt that many people have got a great deal out of listening to you there.
There we go.
So there are we have acknowledging we've run over, with permission of into sort of eating into Claire's time, but we do have quite a long break scheduled. I think it's important to address 2 questions that have come in on the Q&A system. Naomi's asked the question, can you tell me how the NIHR NICE rolling call fits with this? Is it the same 6 calls a year or a separate call?
So the NICE rolling call, we basically operate kind of 2 branches for our committees. So the NICE rolling call sits along one side of those, so it aligns with 3 call closes, and I think I'm right in saying it's our January, May and September meeting which sees those. So that will be the corresponding call 2 months back from that. Because alongside the other one, we have got the JLA priority call. So that's how those are split. There's nothing to stop you putting in, you know, a priority that has been flagged up through a NICE research recommendation into research load at any time. We have a mechanism where we get feedback from the NICE team just to make sure that the research that comes in is still relevant and needed. But as I say, that's 3 times a year officially.
Thanks for that, Suzy. And just to acronym bust, JLA stands for the James Lind Alliance, for those who haven't come across that. Hopefully you have, because they're absolutely vital. Priority setting partnership work there is really helpful to consider. Lucy's asked a question, which I think is a common one we get asked, and I think is worth giving some airtime to. Lucy's asked, what counts as social care? Does this include third sector providers, commissioned agencies? Thinking about substance use commissioned services, hospices, homeless hostels, mental health recovery groups. And then she's put in brackets, probably not registered charities, but community-based activists supporting community members. Yeah, that's pretty clear question there.
Yeah, so we would welcome research from any of those.
Yeah,
you know, anybody who's providing health or social care, very aware that lots of instances, you know, that care is provided through third sector organisations and charities in health and social care. So welcome an application from them, or they'd be a partner within an application. So that would all be very much within remit and definitely not excluded.
Yeah. And Teresa's asked a good question, which is provocative, I think. In pre-hospital ambulance research, we've encountered ethics feedback which hampers inclusivity efforts. Are there plans to educate such boards to be less risk averse, please? And
well, we can absolutely take that back as feedback.
Yeah, I'm not aware of specific education. That's an interesting issue, isn't it, about how we influence the ethics boards, which might vary around the country and so on. So really interesting question, Teresa, and we could perhaps take that question over to Twitter, as it were, and have a kind of bit of a public conversation about that. But thank you for asking that. So
sorry, can I just ask a very quick question? Only because this is something that we get asked all the time. The examples you showed, Suzy, were ranging from about 500,000 to, I think it was 2.4 million. I mean, we all get asked about, how do you feel about smaller studies, and in particular, how do you feel about the sort of feasibility pilot studies with HSDR, or do you prefer them to go to RFPB first, really?
No, there's no question of you know, preferring them or sending them sideways, sort of thing. When it comes to the remit and competitiveness triage step, if it's a smaller study, and you know, it would literally have to be single site or very localized, we would then recommend that they would be more appropriate. You know, they would be much better suited to RFPB. So it's never a case that we would not accept an application if it fit the remit of the programme, if the scale of the study was sufficient to have that generalisable learning from, and if it's a feasibility or pilot study that produces some standalone learning, then that absolutely would be accepted to the programme. So I don't want anybody to think we would, you know, this 800,000 or that kind of level of funding is essential. Very much welcome, much smaller, you know, perhaps more niche studies in a way, or you know, something that's, for example, if we see modelling, routine data types, sort of, or evidence syntheses, for example, all of these things the programme would fund and would be much smaller in cost. So the range is there.
Okay, thank you.
Thanks for that, Suzanne. I should have welcomed you. Suzanne's one of our other Research Design Service site leads. You're very welcome, Suzanne. It's great to see you here this morning. Okay, so if it's okay with Claire, we'll just keep going, because there are some more helpful questions in here which do seem worth mentioning. Neil has asked, I'm interested in rapid evaluation and social care partnerships. Would be good to find out more about these teams, but I can't find websites. Can you point me to websites or other information?
So that team is brand new. It's only just been funded, and so we will not be, as far as I'm aware, we're not looking to fund another one until that comes to the end of its contract, which will be 3 years from now. So that information won't be up on the website. Once they get underway and they start producing outputs, then those will be listed on the funding and awards website, as in a similar way that they are for the for the other rapid evaluation teams that we posted. So you could put in an application for a rapid evaluation, but it wouldn't be a Teams application. Does that make sense?
Great. Well, one final question, which has come in as an anonymous attendee, and I think you've answered it already, because you highlighted right at the beginning that most of the bids are mixed methods, but somebody's commented on historically health research hasn't seen qualitative methods as having much value. What value does qualitative research have for this type of funding? Well, I know that Claire is coming on, so I think we shouldn't steal too much of her thunder. You've got great experience in this too, but Suzy, let's get the word from the managers for you as well, just on this topic.
Well, quickly from me, qualitative is essential. I think it was very, very rare, really, for us to have a study without any qualitative work, because how else do you know how things are being received by real people, unless you talk to them?
Yeah, I hope that's okay for our anonymous attendee. Okay, right. Let's call that a wrap on yourself, Suzy. I think you've given us a very clear message that you're here to be spoken with, and thank you so much. And I won't hang around and pass the baton over to you, Claire. Thanks for your patience and being here this morning. And what we'll do is I suggest that we run into the coffee break by some minutes, and don't feel pressured because people can step away and come back to the recording if needs be. So I think you've prepared a talk for us, so straight over to you, Claire. Thank you for being here. I'll let you introduce yourself.
Hi, can I ask, can you see my screen?
Perfectly. At the moment we can see your display, you know, the mode of the slides down the side and the slide in the middle, and I suspect when you click that's now a presentation mode.
Right. Okay. Well, thank you very much. I'm delighted to be asked. I'm Claire Goodman from the University of Hertfordshire, and also part of ARC, East Applied Research Collaboration, East of England, and that will become a little bit more significant as I talk. So today I've been asked to talk about my experience of funding with HSDR. So I'm going to give you a little bit about who I am. I'm going to talk about projects I've worked on that were and are HSDR funded, and have a go at trying to unpick in what way they're different, say, from the Health Technology Assessment Programme grants, RFPB, and so on. Talk about the core elements of those grants, and reflect, because I'm old, on a shift of emphasis in the focus and methods of the grants that I've been working on, and take the example of care home research, which has been a major focus of my work, and hopefully there'll be time for questions. So who I am, I'm a community nurse by background. It's a long time since I was clinically involved, and my PhD, which was the sort of platform really for my focus subsequently, doesn't always work that way, was policy, looking at the internal market in primary care. For those of you who are old enough, GP fund holding and how it affected community nursing services. And I think that immediately signals there were two issues there. There was a policy interest, but also a system and service delivery interest, which has carried through. I led the primary care nursing research unit at UCL before I came to Hertfordshire. And I think it's just worth putting that up, because such a thing doesn't exist now and wouldn't exist. And I think it's a measure of how we think about services, that we are less and less preoccupied about individual roles and more about how different roles interact within systems of care. So you may still be interested in new roles or new developments, but it's not professionally led research. So my early work was on the organisation of community nursing services, and it did have that unidisciplinary focus. But I would say that in line with what I see is of interest to health service care and delivery programmes, it is that interest about how different ways of working fit into systems of care. And this has been a bit of oral history for me, looking back. My first nationally funded study actually was a policy research programme grant, and it was looking at a policy initiative to introduce quality initiatives into service delivery. And I was reflecting on it. It was looking at care homes. It was looking at how district nursing services could work with care home staff to improve quality of care. And actually, I think it was borderline whether it was a policy research program grant. It was a call I went for, and I think I was very naive in those days, but maybe we can revisit that about how some studies blur between different programs and some are clearly sitting in HSDR. So, as I say, I'm old, and so this is a list of all the HSDR funded work that I've either led or been an active co-op on. And there was an interesting question about funding. So the first one was looking at different ways that nurses were involved in case management to improve the outcomes of people living with what we now call long-term conditions. In those days, it was chronic disease management, £309,000. That was a 3-year study. And through to different studies. So the earlier ones were looking at interprofessional working and topic. I kept coming back to care homes, but also worked with Trish Wilson on looking at different models and ways of involvement, the patient and public involvement. And I think that had an effect on subsequent studies. Had the huge privilege of working with Professor Francis Bunn, who sadly died last year, huge loss to our community, around looking at comorbidity and dementia, optimal study. The only study that doesn't have an acronym, it really was just about optimal working. Shared decision making, that was also Francis who led that. Engaging with GPs in service development and quality improvement. So that was a GP focused study led by Adam Gordon at Nottingham, but it came out of earlier work that identified that the engagement of GPs made a huge difference to how quality improvement was threaded through care homes. And then finally, the Datcher study, which has been funded for 2.3 million and is now in its final year, which is looking at how care homes can be enabled to participate in research and also crucially, how to develop a minimum data set that is usable and useful for them, as well as the many different stakeholders who also need that information. So a long program of working, a long several years since 2006 of benefiting from funding this work. So what can I say about all those studies? Interestingly, having listened to Suzy's presentation, I reflected on the fact that I think I'm almost sure all were responsive to an NIHR commissioning brief, apart from maybe one of the ones that I was a co-op on. So I haven't gone down the researcher-led route. I've always gone down the responsive route, and that gives a very good structure because those commissioning briefs are very clear. All those studies are linked to NHS innovation or service challenges for a particular population for older people. And in my case, the programs of work are looking at health and social care. So as the title was, how it intersects. All the research teams on those projects represented different disciplines, and crucially, everybody had a specified role. So I would say we work quite hard on those different studies, not to have someone with generic expertise, that we can articulate in our proposal exactly what that person's going to be doing. I don't think any of my bids have ever had less than 5% contribution to reflect that. And I think that's an interesting thing to explore, because sometimes you want to give the weight and heft of expertise to demonstrate that you know what you're doing. But the reality is, I think to deliver particularly these kind of programs, you need to be very clear how people are going to enable you to deliver on what you're proposing. Huge interest in how organization and configuration of roles and services affect outcomes over time. And a lot of those studies that I described had a tracking element, looking to see what had happened to older people living at home, what had happened to residents in care homes over time. usually because of the constraints of funding, we never managed to track people for longer than 9 months, but it's also qualitative data. So looking at how they use different services at different points, where the points of exacerbation are, as well as the numeric data about service use. All the studies have an economist involved. All of them are mixed methods. All of them are either underpinned by an evidence review, or as in the ones that I showed you about comorbidity, that was the major focus. And you're going to be hearing about patient and public involvement, but it is such an important element of HSDR. It's what grounds any project. It should be the starting point. It's difficult. And I think any grant that doesn't acknowledge the difficulty and the funding and the fact that you need to have people who have that as their dedicated role to make the patient and public involvement engagement work would raise questions. And so in these studies, I think we've had co-applicants on all the studies. So that's somebody who's named, and it's often a family carer or somebody who's heavily invested. We've had co-researchers, and that has been done in different ways, of where we've had PPI members facilitating focus groups with researchers in care homes, but also enabling recruitment, going in, because very often we have found that older people want to talk when you go through a consent process, and it's not reasonable just to leave them hanging. So our PPI members have accompanied researchers to carry on the conversation, to elucidate and so on, so that there are this support of people who we approach. Standalone advisory groups, we've done it different ways in different studies. So in a lot of our studies, we've had dedicated a patient and public involvement panel who work alongside, as well as having PPIE members involved in the research management team meetings and so on. And residents, so I'll talk a little bit about that with the current study, of where we're working with the National Activity Providers Association to facilitate discussion groups with care home residents about what we're doing and what is important to them. And I would just signal for those of us, as we are thinking about social care, that we are increasingly recognizing that the staff who are involved in direct care, so not the managers, actually have a public or engagement voice that is often not heard. And so we have included staff who would be considered as your frontline workers, not as people who are, well, a part of the study. They will obviously be contributing to data, but also separate members of staff who are commenting on the study itself and its usefulness. So thinking back from 2006 to now, what has been the shift in focus and approach? And again, I think Suzy highlighted some of the things that HSDR were interested in. I would say in the work I've been involved in, there has been a very noticeable focus from single roles and services to asking what models or key characteristics of those models seem to be effective. And that drives us to particular research approaches like realist approaches. It's looking for the key characteristics of saying, what is it? How, because it's not the starting point of any HSDR project, I would suggest, is it's context sensitive. That's not a finding, that's a starting point, that everything is driven by the context and the service. And we know the NHS is a national provider, and even more so in social care, it is so locally determined and driven by local economies. So that's your starting point. So therefore, looking for the key recurring principles and points of impact in service delivery, I think is the shift that I can see in the work that I listed up there. So that takes us to theory driven and theory testing. And again, Suzy mentioned this, increasingly we have implementation relevant questions and implementation focused data collection threaded through the study. So the Datcher study has Ian Lang from Exeter as our implementation lead, who is tasked with constantly collating the information about how is this study being received, where are the points of pressure, the points of enabling, as well as doing the evidence reviews that informs how we would implement what we're proposing to do. I think there is, in my particular programs of work, an increasing skepticism of solutions that favour health needs over social care, and that's quite difficult to navigate. And because obviously we've seen in the current pressures on the NHS, huge questions around, well, why can't social care accommodate these people? And a commitment, which I think is reflected in the shift that Suzy has highlighted, that one doesn't just accept the health issue as the driver, that it has to be looked at from both perspectives and framed in ways that are relevant for those who are oblivious as to whether it's health or social care, but obviously it's crucial as to how the service arrives through their door to support them. Recent studies, much closer working with policymakers and service commissioners and managers to share and test early findings. So we're not waiting, and that's again built into our consultation programs, which in earlier studies we didn't have. We would tend to just wait for the findings at the end and have a big event and then briefings and so on. But that is now threaded through. And a very strategic recruitment of study steering committees. So recognizing that, yes, they are there for governance. Yes, they are there to hold us to account methodologically and to keep us to the protocol. But as importantly, having a study steering committee that actually can see what's coming over the hill. And in HSDR, there is such a rapidly changing service environment that the study steering committee, as critical friends, has become really core and much more important to our studies than I would say when we first started, and a wide range of dissemination of methods and briefings that start from day one of the study. So I'm just going to talk about care home research a little bit to try and illustrate some of those points. So this is a diagram that came out of a 2013 study, which was asking about, well, how do care homes work with the NHS? What is it that influences the different outcomes? And this was a diagram that Steve Iliff, who was an academic GP on the team, came up with, having when we were, and essentially he sort of said, well, what you're aiming for is the middle of that intersection where people actually are confident working with each other, and where both the need for relationships and informal and formal encounters that care homes identified very clearly as needing, that they need to feel that they are equal partners with those who were visiting care homes, and they need support. They are very keen that they're seen as that their residents are not seen as individual people necessarily by visiting health service, but they're recognized as a population that the care home staff need help in recognizing deterioration and discussing issues that are not quite clear. So that's what care homes are looking for. But equally, what was very clear was visiting pressured NHS professionals were very keen to have some kind of boundary and service specification about what they were going to do with care homes, that they wanted to have a structured and efficient use of their time, essentially to be able to factor in care home working into the wider needs of their caseloads of people living at home who didn't have 24/7 support. So these were the two narratives, and what we observed in the approach study was the need to negotiate those two positions and find ways of working together that could bring people to the middle, so that you could have meaningful working valued relationships that also took account of how the NHS needs to be able to work for this population as well as others that they are responsible for. So that was 2013, and that fed into the optimal study, which basically repeated some of the work that we'd done in approach. We did a survey of surveys to look to see how time over time NHS was working with care homes and found inequity. So, and post hoc, ad hoc approaches. So those kind of patterns of working, we identified there was no system for it. So therefore, we then went in and we said, okay, well, we're going to look at different models of how people configure their services around care homes in 3 different discrete areas. Using additional funding, all 3 areas had put extra money to working in with care homes. And what we found by tracking over time how residents worked and how the services were configured, that the same resources achieved different outcomes. And actually, yes, those services that had seen NHS work with care homes as legitimate and not just something to throw some money at to save it being a problem, that saw them as equal partners worth investing in, saw care homes as part of that economy of care. So it wasn't just a single one-off community matron working with care homes. It was actually, yes, dedicated services, but those services were connected to other NHS services. There was a wraparound care. And crucially, that both the care homes and the primary care NHS services could access dementia specialist input for this population who presented with sets of needs that certainly the NHS was not at that time particularly well versed in. And a lot of those findings fed into the Enhanced Health in Care Homes framework, which was then subsequently launched. Which wasn't the sole cause, but it was a good example of where the findings were able to link in with service delivery changes. So that brings me to the DATCHA study. And this one is current when in our last year. And just a few reflections on why we took it to HSDR, and you might want to have some questions about this. So, and I start off by saying it's applied research collaboration supported and initiated. So a lot of the thinking that went into this was bigger than one team and one lead investigator. We took some of these findings to the National Care Home from the earlier work, and we invited other people working in care homes through the applied research collaboration to talk about, well, what are the issues? How are we working? Because in social care, what you have is multiple small businesses. So you can have lots of pockets of expertise. And one of the questions that we were interested in is how can we reduce the level of description research, and how can we raise the level of research that's based on, that has that as a foundation. And so out of those meetings that were ARC facilitated, and I would stress that, you know, all the ARCs have got researcher groups and ways of connecting. We focused on areas around the need to standardize information, the need to reduce research waste, because it's very time consuming recruiting in care homes and in social care. And there were multiple meetings of people who were interested. Sometimes we had duplicate interest, so we had to then negotiate who would be the best people to take part. And a bid went in, and also simultaneously some of the findings from the ARC deliberations had been fed into the commissioning brief. So there was, I wouldn't say it was influence, but there was a sort of awareness at NIHR of what care home researchers were saying were the issues, and sort of, if you like, a priority setting exercise did feed in to the commissioning brief. We submitted a first stage submission, and this is a real plug to pay attention for feedback. So essentially, there were lots and lots of questions about this bid. There was quite a degree of, really, can you deliver this study? And also a recommendation that we should work with the Health Foundation as people who are very knowledgeable about data integration, particularly from routine data sets, which we did. And we had, again, more meetings in that 8-week window that you get with the Health Foundation, and they came on board, and that pushed us over the 2 million bid mark. We'd strenuously tried to keep it. We were aware this was at the top end of what HSDR would normally fund, but in response to what we were asked for, and I have to say that was a game changer. So we took the route, as I said, this was an NIHR brief of addressing all the brief. It could have been, you know, a standalone study just looking at reducing duplication and research waste in care homes and looking at what supports implementation. But first part of the study is addressing those questions. And then the second part of the study is addressing how to improve and standardize data, information held by care homes that could be useful and usable for care in the care home, but also by all the different stakeholders, commissioners, CQC, family, who want to know about what is happening. Now, of course, we started this bid, bid was awarded, and this started 1 month before COVID hit. So this is what our aims were: establish what data needs to be in place to support research, service development and innovation, and to synthesize existing evidence and data sources with care home generated data. So suddenly something that had been a care home researcher community obsession and interest and built on lots of care home research became a national priority. And suddenly we went from having a design where we believed we had to persuade people this was really important, to having to make sure that government policy didn't overtake and move faster and ahead of the evidence of what we were doing. So this is the diagram. It's actually an old diagram because we've subsequently, with the studies within a project funding extended work package 5, you'll see here in work package 5, it's talking about working with 2 integrated care systems. We're now working with 3 and seeking, as we speak, to recruit 60 care homes, which is a battle. But really what I want you to take from this picture is the progression of the grant and the idea of the implementation element. So discover. So this is the evidence reviews, looking at implementation practice, and how outcomes and assessments are done in care home research. Then the define is actually articulating what we found from that work and from our national survey work of what data is already being collected and how it's collected, to developing a minimum data set, to then delivery. And running alongside all of this work, we have patient and public involvement. Sue Fortescue was our first public involvement co-app. It's now Pamela Blades, because Sue sadly died. And we have patient and public involvement in every single of these work packages, and every work package presents at key stages of development what they are doing to the panel for discussion, and then comes back midterm and interim to get that ongoing feedback. And we have national consultation, which in the original bid was regionally organized, but with COVID had to go online, and we worked with the Discovery to do an iterative consultation process, extending our consultation with key stakeholders. So as I say, that's pretty impossible to understand, but I think if you look at the pattern, you can see there is mixed methods, there is patient and public involvement, there is consultation with all the different stakeholders at key points of the study. We do not wait to the end. And we are working towards a prototype, and picking up on Suzy's point about future proofing. One of the biggest challenges has been keeping up with all the changes. So I'm just talking a little bit about impact, implementation. We can debate the words. We had to write a position paper on what we meant by minimum data set, because very quickly it became apparent that that was not an agreed term. And that was published in Lancet Longevity, our 9 core principles, and that's been a really useful place to bring the study to all the different stakeholders. Regular blogs, every output that comes out of the study has a plain English. This is a screenshot from one of the website pages where you can see on the left, it's what the actual published peer-reviewed paper is, and then the download is the summary, and which work package. And we've got several things under review at the moment. Maz Musa, one of our research fellows, has got his PhD after leaving us, but it was in care home work. Jenny Burton has a Senior Clinical Research Award Fellow. Guy Perrier has now moved on to an NIHR Knowledge Mobilization Fellowship. Anne-Marie Towers, I'm sure it's not down to Datcher, but became a professor, and Adam Gordon became a Senior Investigator Award both in the last year. And Lisa Irvin has a School for Social Care Research Fellowship to develop the work she's doing on a trial repository, which is one of the resource developments. And Anne Killett has just been awarded the Chappie study, which is extending the resident involvement work in care homes from the study. We have a webinar program and planned face-to-face events. I've talked about the consultation online methods working with Discovery. And because of COVID, we moved to working with software providers. So this minimum data set from care homes, which will link with routine data in the 3 integrated care systems, is being engineered in partnership with person-centered software and Nourish software. So that's taking us further and quicker than we originally planned. And we are also, which is becoming vital, meeting with Department of Health and Social Care and NHS England Innovation and Implementation quarterly, to make sure that our work complements and doesn't confuse what they are also doing in this crowded space now around social care records, standardized social care records, and minimum operating data sets. So in summary, in all these projects, there wasn't an HSDR formula, but there were recurring characteristics around multidisciplinary working, patient and public involvement, and inclusion. I think I've shown the scope to build cumulative programs of work to sort of, HSDR doesn't really focus on policy, but you can say, right, this seems to be a key issue. We're going to take it back to HSDR to develop further. I think we have benefited hugely from who we have partnered with as co-apps and in our study steering committees. And that has been a game changer in being told very early, this is not going to work. Working with the ARCs in recent time has been very helpful in extending our national reach. We immediately have 15 ARCs who we can collaborate with and make sure we're not duplicating. Suzy highlighted that one of the issues is that everybody has very similar ideas. So how can you move your research to a place that will capture something that is nationally relevant? And I suppose the learning from Datcher, which we've had to learn on the foot, is how your research can adapt in a rapidly changing service environment and the need to future-proof. This is the Datcher team. As you can see, it's huge, but I would say that everybody is making a particular contribution at different stages. So some of the funding is front-loaded for some of these people, other further down. And everything you've heard are my opinions and not anybody else's. Thank you.
Claire, the absence of a live audience to give you a round of applause is something that I always miss on days like this, but thank you. That was truly inspiring, and congratulations on your sustained work over the years. It's really great to get some insights into your experience, and yeah, absolutely really enjoyed that. There aren't specific questions that have come in while you were talking. There was a question about how public contributors can be involved in this work by Sil, who and Tracy has answered in writing with some resources in general. I'm not sure if that specifically answered Sil's question, but what I'm thinking is we've been going quite sustained now since we kicked off to 10 o'clock, so we probably should just allow our audience a 10-minute break. We'll kick off again at 30:30, and we will continue to address things in writing over on the chat box. Oh, I'm just seeing Susan has posted a question. Thanks, Claire, really helpful. I wondered if you could give some examples of outcome measures used across the various projects you've mentioned.
Okay, I suppose always resource use, because obviously that's if the service is of interest to that. Other outcome measures, certainly in DATCHA we're using standardized outcome measures in the minimum data set, but also a lot of qualitative data looking at how people use services and guided by implementation frameworks. I mean, you'll have seen a lot of those. The later ones have had a realist drive to them, and very often when we've been doing realist studies, we start with the outcomes, what matters to people who are using this service, and that frames it. But so it was accessibility, those kind of issues.
Thanks for that, Claire. Okay, well, as I say, in the absence of further live questions, it was such a comprehensive talk. It's I think wowed us all as well, Claire. Thanks for that. That was really, really super. Oh, another, yeah, and I think Susan's just thanked for the answer. So that's great. So look, it's 11:20. We did originally schedule a half-hour break. Sorry, folks, to intrude in your coffee time, but I suppose the benefit of online working is that maybe some of you already grabbed your coffees, but if not, let's get back on time at past, and we'll run and take a short comfort break and see you back on time to hear the next part of this webinar.
Hi, Andrew.
Hi.
Can I just practice, make sure I click on the right thing, if that's all right?
Absolutely. If I stop sharing. Good to see you, John.
And you. It's good day.
Really, really enjoyed this.
Yeah.
I'm conscious actually, I might just pause.
Hello.
So, right, we're back recording, and we're here for the last part of our webinar about the Health and Social Care Delivery Research Programme of funding. So I'll hand the floor over to you, Charlotte, to introduce yourself and talk us through some of the things you wanted to share.
Thank you, Andrew. Hopefully everybody can hear me okay. So it's really lovely to be here with you this morning. My name is Charlotte Williams. I'm the Chief Strategy and Improvement Officer at Mid and South Essex NHS Foundation Trust. So that's a very large hospital trust in Essex, and I'm a member of the trust board there. I was approached to join the webinar today because I've just actually finished after 6 years serving on the HSDR funding committees as I believe it's called an expert commentator or something similar, which sounds very highfalutin. I'm not an expert by any means, but I saw an advert in a newsletter to join and take part in assessing the applications for HSDR and thought it looked really interesting, and so I was happy enough to be accepted to do that, and did that for the maximum amount of time possible. We're now being stood down and just helped by occasionally reviewing applications that might come to the committee in future. So just to give you some insights really in terms of how I think about the research applications that I've seen over the years and sort of key success criteria I suppose I'm looking for amongst one of many people on the panels, and how I approach that as somebody who's been in the NHS for 21 years now in various different roles. So I've worked in hospital operations, I've worked in commissioning, I've also done a little bit in public health, and I've worked at one of the academic health science centres, and now I'm obviously working in strategy and digital services. So range of experiences that I try to use to be helpful. I've also had a little bit of, had a little bit of involvement with research into practice in my work in the Academic Health Science Centre, so I do understand a little bit of the NIHR infrastructure. So I've just got one slide where I was just going to put up the kind of 4 key points that I tend to use, as I thought it might be helpful for you to have something to look at, and I'll just talk those through and take any questions if that's okay. So I'm just hoping I can share screen with me, if it's going to let me do that. Okay, so I'm hoping that this is, can you just, somebody just tell me if that's displaying okay?
It looks like it's coming. We've got, yeah, we have a.
You got one slide with 4 points on it?
Yeah, that's right. It's on the mode where we can see the side panel as well as the main thing, but it's perfectly readable. Okay,
I'll just I'll try and make it, but on mine it's showing as a slideshow, so I can't see anything else now. This is helpful. Anyway, so apologies for that. I can see a full slide and you can't, but anyway, so yeah, I'll just talk
it's now disappeared.
Oh, okay. All right, great. This is helpful. Sorry, everybody.
Quite okay. It was perfectly readable what you had put there, and as you say, it's only one slide, so.
Yeah, no, I'm just trying to work out how to do this. I'm not on my usual screen today. I'm out off somewhere else. Okay, all right, fine. We'll just go with this one then. So here we go. Here are the 4 kind of key things that I think about. So the first is obviously the relevance of the question or the topic of the research. So sometimes they are commission calls from the DH or from NHS England or otherwise. So there's obviously a relevance to the topic. Sometimes it's researcher-led studies. So sometimes it can be people's interests. So obviously it's public money. So I have to be really clear in thinking about, does the topic actually address a question that really exists, and what would be gained and for whom? So which is the population that's going to benefit? Is it staff? Is it service users? Is it the general population? Is it future patients? And why don't we already know the answer to the question? So that for me is really important in terms of, is it one of those things where everybody thinks that they know, but there's actually a research gap, or what's the reason for the question being investigated? Obviously, whether it fits with current national policy, so it's something that's likely to have relevance in terms of what we in the NHS are being asked to do, given that most of the time we get asked to follow policy and have very regulated system and process, particularly within the NHS, but also in social care. So is it aligning to that? And is the area currently underserved? I think I quite often look for research that's not just into the same things over and over again. So the whole idea of HSDR is that we can do health across NHS and social care, and we need to be inclusive and think differently about providing an opportunity for different kind of researchers as well to come in. So what is it looking to address, and what are the range of people involved in the research team? So for me, if you want to do something looking at hospitals where I work, it'd be crazy not to have people from hospitals involved in the research team, because obviously they're not going, it's only ever going to be so relevant from my perspective if it's done simply by people sitting in university, even if they hold a role within the NHS as well. I still think it's really important to have that diversity on your research team, and have they thought about any competing priorities or interests? So are there any policy directions that are actually flowing against or that may conflict with the question? Has that at least been thought about, even if it isn't necessarily known directly at this point? Because obviously there is a couple of stages to developing the research where these things can be teased out, and the role of me on the panel is not just to assess the research, but also think about how it could be improved, or how we can provide input to help the researchers to develop a good proposal or to learn for the future as well. So those are some of the things that I think about in that area in terms of the relevance of the question and the topic. I don't really look very much at the skills of the researchers, because I'm not an academic researcher, and I don't break down the methods and the health economics or anything like that, because I have colleagues on the panel who do that, on the committee who do that alongside me. So this is really where main area of where I'm focused, particularly in the first stage of any proposals. The second element is the size and scale and scope of what's proposed. So where and who, and is it inclusive? So quite often we have some parts of the country that are constantly bringing forward proposals. There's less opportunity perhaps for other parts of the country to take part. Why is that? Why is that being chosen? What are we missing out there? And is it, are the settings relevant and has a wide range of different areas being considered? Obviously it's still got to be feasible. We can't have everybody involved in everything, but needs to be some thought processes in there about how certain sites or groups or areas have been selected. Have any roles or stakeholders or key groups been missed out? Sometimes you find that that can be, for example, you can see research into how people receive care from providers, and actually providers haven't been included, or the organisations that represent providers haven't been included. So who could help make the research more effective or help the delivery of the research? And who is actually for? So who's going to be the beneficiary of the research outputs, and how would the researcher see it being used? So that's the sort of research plan bit for me. And then the next bit I think is also really useful for NHS professionals like myself to have a view on, which is around the approach and the methods and the timelines. It's often one of the big areas of conflict between people like myself who want to use evidence to make change, and those researching and producing the evidence is the timeliness and the usefulness in terms of the how well it's been developed in the real world. So for me, this is a really important one, and we mustn't just discount things because they're not already very well trodden research paths. Again, I think part of my interest in this is about doing things differently and testing some of the less traditional approaches, particularly to things like co-production or engagement. How can we bring in novel methods and encourage those? Because the more that we use them, the more substantiated they are, I suppose, in terms of their involvement in the research methods that we recognise. So keen that we have a role in doing that. The feasibility of conducting this research, given how constrained the NHS and social care is, any structures or assumptions that have been made, which may or may not be true or may apply in certain parts of the country and not in others, and assumptions that have been made around particularly things like data access. Most research groups are pretty clued up on how they're going to get data and how they're going to link data and things like that, but there may be some considerations there to tease out, and assumptions about participation and how that might be done. So also this element of timescale. So it might be something that's really big and complex and going to take 4 years, to complete, which is probably fine. But if in 4 years really the whole ship will have sailed, the world will have moved on for various other reasons, then is there any way to accelerate that or to get some interim outputs or to think differently in a way that might be more useful? Or is it slightly going to be irrelevant by then or slightly overblown in terms of scope? Obviously, EDI, patient public involvement, and the involvement of addressing health inequalities where that's relevant, really important. There are PPI specialists on the committee, so you do need to understand what good looks like in that area. And I think the key thing for me also is that it isn't just outsourced. So it isn't like, well, we've got this person that knows how to work with these communities and they're going to be a partner in the study. That's a sort of slightly absolving yourself of the need to get involved and understand your participants or the communities involved. So it isn't just outsourced, it is actually researchers getting involved and engaging properly in undertaking responsibility for that aspect of the research. So that's something that we look for. And again, there are EDI specialists on the committee, but you pick up and learn an awful lot from them in terms of what we'd be looking for. And then finally, big one is obviously dissemination and path to the use of the research. So a number of times something's going to produce a toolkit for people like me to use. I can't keep up with the number of newsletters I get with toolkits or links to them every week. So that may be the right output, but how is it actually going to land and how will it actually be used by people who are getting 1 million emails a day or who have very little time to understand how the evidence is moving on in their sphere of practice? So who can help with that? And I think this is a really important part of the committee's role, is to help make connections for researchers to those organisations or partners that can actually influence the impact of their research, assuming that it's successful and that there are good outputs. So How will those findings be influential? You know, are there groups, individuals, societies, networks that could be linked into the research during its development that would help with the dissemination and the impact, and how it's actually going to reach people? So there are obviously multitude of communication channels, lots of conferences, and there are lots of things that serve researchers really well in terms of sharing the research and how they've done it. But if it's going to be useful in application to policymakers, to commissioners, to providers, to those supporting NHS and social care services, how will it actually reach those people in a way that's going to be useful for their work? And that's what I'm there to look for. Now, not everything's going to tick every single box on that list, and there are obviously different types of research that will aim to achieve different things. But you asked me to say what I look for. These are the things that I look for as an NHS member of the panel. So that's, I'm just going to try and close my window down now and see if there are any questions.
Great, thanks, Charlotte. That's really super, and distilling 6 years of panel experience into 4 points like that is very, very helpful. I wondered if perhaps we should give a little bit of insight into how the panel works. I know Suzy spoke a bit about this as well, but your role as an expert commentator, did you sort of own certain applications as well, or was that led by others?
Yeah. So Suzy and I did liaise about who's going to talk about what, but yes, that's right. So there are designated committee members to consider each application at each stage, and there's a mix of people from different backgrounds who are selected to do that for each application, so that you get the rounded view. And also there are designated responsibilities for looking for diversity and inclusion, for example, or for patient public involvement. So there's generally, generally a different set of disciplines involved in assessing at each stage, and obviously at the later stages there are external reviewers involved as well, so you've got both the application itself and also the view, the response to the first stage and the comments from the reviewers to consider. So and I think Suzy can correct me, but I think now the intention is that if you've seen an application at stage 1, you would also stay with that application at stage 2 to make sure that you can see the evolution of it over time and understand as much as possible. So I think, you know, subject to people's availability to attend a committee, as much as possible we've tried to do that, and that's actually I've really enjoyed that, because you can see how a project gets developed and really have a lot of confidence in its success if it's funded through that route as well. I don't know, Suzy, if I've got that right.
Yeah, no, absolutely spot on. I mean, that was one of the you know, the good things about restructuring our committees, because I said before we did have separate people. I think Charlotte, when you first started, was just looking at the stage 1s, our prioritisation committee, because that was very much service focused, and the stage 2 committee was more sort of academically researcher heavy in membership, and so there wasn't that real connection, and I think it's worked really well, the restructure. And as Charlotte says, the way we manage that is to try and have at least some of the key people. So for each application, stage 1, it'd be a public member plus 2 others, expert speakers who introduce it to the committee, so they'll have read it in depth before the wider committee discusses it. And then at stage 2, it's 3 people plus a public member. So as far as possible, logistically, we try and carry through the same people.
Yeah, I was going to say, can I ask a question? You made a comment, Charlotte, which really intrigued me, I have to say, about sort of EDI and PPI, about what you call outsourcing it. I just wondering if you could expand on that a little bit, because I mean, I think there's a balance between, say, a not very experienced chief investigator or maybe another academic on the team sort of trying to do this work, and as you say, maybe they're not an expert in it, but they're having a go, versus, as you say, yeah, there are people out there, I think, that you can that you could pull in and pay, and yep, they do it all for you, as you say, and it's you've effectively, I suppose, outsourced it. I mean, I'm kind of thinking what you're looking for, or what you're describing there, is you're looking for some kind of balance between the two, that, okay, you've got this great person to do it, but they're not really a part of your team, you brought them in, versus you're trying to do it yourself, but you're not very good at it. Sorry if that, I don't know if that comes across as a very good question, but yeah, I would be sort of a bit intrigued to know where the, or if, I'm sorry if it's a bit of a difficult question to answer sort of off the top of your head, what would look right, as it were, somewhere between those two extremes. I think Charlotte's frozen.
Oh. Yeah, I think you're right.
I don't know if Charlotte can hear us and wants to answer. Should we give her a minute? Otherwise, I can try and answer that.
Yeah, it looks like she's just frozen for the moment, so I'd go for it, Suzy.
Yeah. So I think what occasionally we see in applications is, and quite possibly because the team doesn't feel confident, they'll say that you know, the PPI lead is to be appointed, or there's some work will be done in the future.
Okay.
That feeling that there hasn't been any engagement, any kind of preliminary conversations, working out exactly what the issues are that are important to people, and sort of embedding the PPI right from the start. It's that embedded feeling that it's not just a standalone element, it's something that should shape a whole application really all the way through. So where it is packaged up as an element that's going to, you know, get sorted out once a team knows they've got funded, that doesn't sit very comfortably with the committee, because it suggests that those issues haven't been really thought through and woven in to the whole structure.
I was going to say, I think there's a question on the question and answer that sort of follows on from that. So, but also Tracy's got a hand up. So.
Yeah. Yeah, well, I think that's right. I think the question about involvement of third parties, like a specialist advocate group taking that role, that seems, yeah, let's just finish commenting on that and then bring Tracy in.
Yes, I just, because I imagine that you would want to see some budget in there for that named coordinator role, and depending on whether it's a professional researcher member of the team or it's a public contributor, then it's going to have different costs associated with it. Yeah. Is that right?
Yeah, absolutely. I mean, the coordinator role is an expectation of every application. That role should be a named member on the team. And then the people associated with the team may or may not be co-apps. So the actual PPI members who are bringing that input into the study, and that might be sort of focused around a couple of people, and then there's a broader group is a sort of typical model we see. But very much their time should be paid for, their support should be paid for, any training that's needed to help them undertake their role should all be costed in, and that would be expected. And where that wasn't there, that would very much be picked up by our public members in their assessment of the applications. And you know, those are fixable flaws. Those are things that can be added into an application between stage 1 and 2 if the committee wanted to support it.
I see.
Yeah, and Sil has kind of asked, has commented on that as a follow-up comment, perhaps in the question and answer section, that says, and the costs for PPI go up because a management charge is costed for. And I guess from where we sit in the RDS, we would be encouraging that there should be quote sufficient budget to enable meaningful engagement. But Charlotte, welcome back. You froze for a moment, so I'm relieved to know.
Yeah, I haven't transferred to a different
again.
computer now. Can you hear me?
Yeah, perfectly.
Okay, brilliant. Yeah, no, I was just going to say, in a way, the costs, as long as they're reasonable, I don't think cost, I mean, in my own view, is the main deciding factor. I think high quality research that sounds like it's actually going to work, even if there's however many thousands of pounds in it. I mean, I deal with big amounts of money every day. I know that things cost money, to do properly. I think we have to be clear that it's adding value and it's not subsidizing other activity, and that people are occasionally had applications where it looks like somebody's not getting paid properly or might be not getting paid enough, and I'd rather people are getting paid properly and recompensed, and that research is properly funded. I don't think it's going to make a massive difference to me if it's a few £1,000s cheaper and scrimps on anything, if you see what I mean. So it's definitely a factor, but it's not, certainly not in my mind, the most important element.
Tracy, come back in on that.
Can I just ask another question or a bit more clarification, Charlotte? So we were wondering if you were referring to that, I suppose, that named public involvement coordinator type role and outsourcing that. But I also wondered if you were referring to how we access more diverse groups.
Yeah, it's more about that. Yeah.
For example, if you if you were working through community leaders or maybe charities, so is that what whether you would refer to that as being outsourced, or is, because sometimes
that's what I mean.
Through the trusted people in the community, that helps researchers to sort of bridge that gap to be able to build the relationships with people. It's sort of a bridge to be able to build relationships with more vulnerable or diverse communities.
Yeah, I think obviously working with partners is very helpful, because it does provide a route of access, and it provides guidance and support to researchers. I think the key thing is that if it's just those people are going to run these workshops and give us the findings, or this is going to, I think the key element is really that researchers engage directly and build the skills in engaging with diverse range of communities as part of the research, rather than researching a community at arm's length, I suppose is the point. So it isn't so much about, I'm not referring to a contractual model or a co-application model in terms of outsourcing. What I'm saying is, if you're going to research an experience of services from certain groups, co-production really, or a kind of engaging with that community involves researchers as well as partners. And I think that's something which I've learned very much from our specialist CDI members on the committee, that's how they see it, which is, we're really helping to grow the skills of researchers in undertaking more inclusive types of research through expanding their own experiences, as well as using those groups as sort of subject matter, if you like, for the research. So that's what I'm referring to, more than around having co-applicants, which obviously there should be proper arrangements for that. And I do completely appreciate using whether it's kind of local organising groups or charities or others in partnership of doing that, and they should be properly resourced to do that, and also acknowledged and credited through the research for their involvement as well. So, but it's more about the style, as you say, Tracy, that I'm talking about there.
Thank you, that's really helpful to understand and positive.
I just see Emma has posted a very interesting question about giving an example of best practice in terms of effective dissemination to commissioner policymakers and the involvement of commissioners in the research. And I don't know if there are any examples that spring to mind. I thought that's a very, very useful question.
So if I can give very specific examples, but some things that I have seen which I think are good would be having, for example, if there is a national program looking at something good practice, so whether it's Getting It Right First Time program, or there's a national sort of best practice group in that area, it's always really helpful to have those people involved in the research, either knowing the research is going on or contributing as part of an advisory group or something, because they're going to help. They already have a network of people across England, in that case, who they can keep informed about research that's going on, and maybe can be used to help test outputs from that. There are also other membership networks that exist, whether it's through things like NHS Confederation or the Academic Health Science Networks, others like that, that can be very helpful at already having kind of ready-made communications routes, channels such as forums and meetings, where it wouldn't be unusual for research to be being discussed in that area. I also think sometimes professional regulations or the impact on people's practice needs to be considered of any research. So having links into organisations that oversee particular professional groups can be really important. So if it might have implications, for example, for nursing practice or for education and training, then linking in with those kind of specialist organisations would be good examples of that. I think sometimes commissioners get forgotten as well. So if it's going to be something where you may see care or services contracted for differently, then making sure that you've got a commissioning or potentially a funding organisation linked in. Then those, like someone from one of the think tanks or one of the policy groups could be really useful for that. So I think it could be a lot. It can be a lot easier. We can help out quite a lot by signposting to communities that already exist. In all my roles over the last however many years, I've always been networked in some way to where I'm getting my information from, and NIHR is one of those for me directly. But sometimes it's not normal for managers like myself always to spend that much time in contact with research organisations, but we would in other good practice areas and things like that. Well, so those are probably some examples.
Yeah, Charlotte, that's really helpful. And I think actually we've kind of run out of time, but I think you've been a plug for volunteering to be on panels as well. And the fact that it was so engaging for you for all those years has been really good. And I know that there might be people listening in here today that should consider looking at the calls for panel membership, because your very on the ground experience has really shone through this session. So thank you for that. Conscious that time's rushing by, and we are scheduled to move over to Professor John Wilson and Sarah Ray now. So thank you very much. We can carry on conversations on the Q&A section of the system, and we can also carry over onto Twitter. We've got a hashtag #YourRDS kind of thing that's been rolling alongside this today and in advance of today. So you can catch up with us over there if you want to too. So over to you, John. Thank you, and Sarah, thank you for being here. That's really good to see you, and I'm really looking forward to hearing about your wonderful study.
Thank you.
Thank you. I'm very happy to be here too. I'm going to apologise right from the start that I do have a slightly bit of a frog in my throat, so if I have to make a few sort of coughing and clearing my throat noises, please excuse me. My name is Sarah Ray, and I am someone with what I can only say is extensive lived experience of mental health challenges. However, it really wasn't until I'd been on an adult inpatient ward for over 8 months, it was about 15 years ago actually, that it really spurred me on to influence the design and delivery of services. I just wanted to see if I could do anything to improve mental health care provision, and that led to involvement in a wide range of different research projects and quality improvement initiatives, starting from a very in a very small way, and then gradually building up my knowledge and expertise until I think I'm really now an expert by experience with teeth. I'm not going to say any more, so I'm going to hand over to John because he's now going to introduce himself.
Yeah, thank you, Sarah. So my name is John Wilson. I'm a psychiatrist and I suppose clinical academic, and I am co-leading this mind study with Sarah. And we thought we'd just run through bits of just little snippets of that, because I think it will highlight everything you've heard today. It sort of pulls it together in a real way for me, in a different sort of research for me. Go on, Sarah, you start us off.
Okay. So, yeah, as John just said, we're going to be talking about the mind study, which actually is the full title is Co-Producing Improved Mental Health Acute Inpatient Discharge Using a Systems Approach. And the aim of the project is to improve the outcomes and experiences of those being discharged from mental health hospitals, in most cases back to the community. And John's actually going to say a little bit more about the project in a moment. I'm going to just speak about why I was so driven to get this research underway, and about the way that we've worked together, collaborated to build the team and develop the funding bid. So the reason I was passionate about this topic was because I've had two very distressing experiences of discharge in my adult life. Then Mind, the charity, conducted a large leaving hospital survey in 2017, and that really reinforced my desire to address the problem, because the disturbing findings, and they were really hard-hitting, they mirrored many of my own traumatic discharge, the things that I experienced when I was being discharged that didn't go well. And it was also very clear from the report that this was a national issue. So definitely something that deserved attention. Now, I'm someone who's not an academic. My education was totally derailed by poor mental health. So for me, it was absolutely essential to find researchers who could develop the proposal and conduct the research. In other words, do the work. But it was, so one thing I was lucky, as I said earlier on, I had worked with a lot on different research projects. So I did know a large pool of researchers, and I was able to reach out to them and start floating my ideas and saying, you know, I really think this would be a very relevant and important topic to research, and would you be interested in joining me? So yes, it didn't take me too long actually to get a small enthusiastic team together. And I deliberately only approached researchers who were effective communicators, patient and public involvement or PPI proponents, and without big egos, to avoid hierarchies. In fact, it was a healthcare engineer from the University of Cambridge that I'd worked with before who inspired the team to adopt a systems approach as a study methodology. So that was all well and good, but I'm still an individual who has never led a research study. So I had to think where I could get support, and so this is why I reached out very early on to Tracy, and it was the best thing I could have done. It's enabled me to sense check those initial ideas that I had, and even more importantly, through our conversations helped me to believe that I had the ability to lead a large research study. Tracy and an experienced RDS advisor, Louise Marsland, attended the Minds meetings from the outset, which bolstered my confidence enormously. But at a practical level, it enabled me to get a better grasp of complex research concepts. And that was especially important when key decisions were being made about, so for example, which methodology did we go, how did we choose to conduct the research using whichever methodology. And so, you know, I could have a conversation with Louise outside of a meeting, and she would tell me, she could sort of convey some of the information in a language that I could understand, that then I could really understand what the choices were. And Louise also advised on different NIHR funding streams. And I'm never going to forget how she kept discussions on track with those regular prompts about the need to focus on the scope and be clear about the objectives, because we were such an enthusiastic team. We would be carried away, going off at tangents, thoroughly enjoying ourselves, but not always keeping the purpose of the discussions in mind. So in fact, I owe a great deal to Tracy, because she also made me aware that the team could apply for £300 of RDS funding to support the pre-grant PPI activities, which we were very keen to. We were very keen to have the proposal informed by the voice of lived experience. And actually, I think it was the breadth and depth of our PPI work that was highly commended by the reviewers. So a huge challenge for me was finding a professional co-lead who had been responsible for holding large funding awards and whose PPI values aligned with my own. That was the biggest stumbling block for me, really. I'd already made one big mistake by choosing a co-lead without doing my homework. It was only later on that I discovered that this professor of clinical mental health nursing was already overcommitted. And I had that very difficult task of telling her that she wasn't really the right person for the role. So it was my lucky day when by chance I was sat next to John at a regional East of England applied research collaboration event. We had an immediate meeting of minds, because as I shared my sketchy ideas for research, as I shared my sketchy ideas for a research project, straight away John recognised and agreed how important it was to improve the transition process for people returning to the community in the area of mental health. And during the long application process, it took us, I think it was about 3 years, if I'm right, John, to actually, before we were awarded the funding. It was our collaborative approach that was really key to establishing a level playing field across the wider team and building trust, while still allowing room for challenge, because that's really important. People need to be able to challenge and feel that they can do so, but be constructive, obviously, in the way they do that. And so just as a slight aside, I'm thinking also about, I have found it difficult to find a suitable co-lead, but I can imagine that for academics who are really keen to collaborate with a lay co-lead, they might find that equally hard, really, and that might be something that we could discuss, because of course there is no pre-grant funding for someone such as myself who worked for 3.5 years with no payment, which excludes the vast majority of people, really. Anyway, that's slightly going off there, but I just really want to say that Since the project launched last year, we introduced reflective practice sessions for the core team. However, this was really just building on the way John and I had worked before the funding was awarded. I mean, we'd regularly touched base to sense check how we felt things were going, both between ourselves and with the wider team. When the odd issue did crop up, we were able to resolve the situation quickly. Luckily, at the outset, I didn't know what I didn't know. If I'd been able to look into a crystal ball and see how long the application process would take from the start to the finish, I'd probably never have embarked on the project. However, in this instance, my OCD has been a great asset because it's given me the tenacity to keep going when others might have given up. Now I'm going to hand it back to John.
Thank you, Sarah. Thank you. So we haven't got too much time. I just want to skip over a few points. It has been a challenge, hasn't it, Sarah? Or it's been challenging, I would say, in a good way. It's helped us develop our ideas. In NSFT, we have a research development team. It's quite a unique setup, really, which helps academics to develop their own bids. And I think that gave me access to someone with enough time to start to push the envelope. We had a series of HSDR bids already funded, but they were more traditional, and we've had to develop quite whole new strategies and approach to how we do this meaningfully. Some of our research experience is in service user perspective, but this is really pushing the envelope. Sarah and I realized early on, I think, that we had to come up. We started off, didn't we, Sarah, by coming up with a solution around, I don't know, peer support workers, and we were going to do a trial in this, and then we realized we had to keep going back to something more fundamental. Why was discharge not working? There's nice guidelines. Why is it not implemented? What's going on as a system to stop very clear guidance actually happening in practice, as Sarah talked about for the Minds survey? So we had to kind of go back a bit and start to look at this. And it took confidence, I think, that the HSDR would see the value of what we were proposing. But we've just heard all today about actually this is just what they're looking for. I didn't quite know that at the time. And listening to the stage one feedback as well, we sort of went off and really looked afresh and started to think, well, how are we going to, make this look like proper research? How are we going to have the right people on board? People that do process evaluation, people that do health economics. We already had good links with the RDS actually, and did a research design service. And then how might we develop the grant? So for instance, it's been taught today, the study steering committee, but Sarah has pushed the envelope from what I would be used to having, like an advisory group, to something she wants much more challenged. She wants us challenged at every step of this process. And I'll come back to why I think that is actually. I want to be challenged, but within a comfort zone. She's quite keen to push us out of our comfort zone and does that repeatedly to, for instance, a study steering committee membership. And having Sarah there, I think, has added quite a lot, not just a better chance of getting funded, and you'll see, you'll get a sense of that already, I think, but it's enabled some authentic research to start to happen. It keeps refocusing us back on why are we doing this and what's the point of this, all the stuff we've just heard about earlier on today, actually. And it's really changed my mind about how PPI should be included or involved. I thought I was good at it, actually, but it's really pushing me on that. And also, when I start to comment on other people's bids now around the PPI, I'm more shocked by what they mean by it, actually. I just want to quickly share a screen to talk about our study. I'll just quickly summarize the study. Can you see that? Yeah. Oh, yeah.
Yeah, that's on the view with the slides down the side. That's it. That's the display slide.
Yeah, good.
Yeah, perfect.
Yeah, good. Okay, so the whole purpose is really to improve the discharge from acute wards, but not just from what we're trying to do here is merge together. Staff want to do a good job, so what's getting in the way for them as well? And how do we get that balance right, the power right, actually, as we start to develop a study to meaningfully involve PPI? And that's the bit Sarah's alluding to with the reflective practice. How do we make sure that her voice and my voice are equal, that my skills, if you like, I bring to this, and her skills are equally valued, and come up with something coherent? The study, this is a real snapshot, but there's 3 years. One is to understand the problems I just talked about, to design a system by which it can occur better from everyone's perspective, and then in the final phase to evaluate it. The first bit's a realistic review and evaluation. We're finishing that bit now with lots of realistic literature searches and ward-based observations. We're designing with the Engineering Better Care we're using from the Cambridge University, who are co-applicants, to start to take that information to them along together with service users and staff on wards, and start to design on 6 wards how the process might improve. We're not predicting the outcome. It could be policy, it could be trust board level, it could be a simple thing like having someone on the ward doing something differently. What's needed, and then we're going to test this out on across the 6 wards to see what the outcomes would be in a sort of trial. It's the first phase really of starting to think about this as a program of work, which Claire talked about earlier on. I could go on and on about this, but I won't, because we haven't got much time left. Sarah, did you want to talk about the key themes from your point of view as to what you have learned from the study?
Yes, I think key themes as well, and in terms of applying for funding and to ensure that the study is really relevant to reflective of people's needs and robust in every sense of the word. I think maximising the involvement of people with lived experience from the very outset. So I don't just mean once the proposal has already taken shape. I think this comes down actually to the stage before that, when what the research area is, prioritizing that, and the questions are yet to be defined, involving people at that stage right at the front, and finding out what their views are on the sort of priorities for research is really important. It's no good bolting them on even a bit later, a bit further down the line when the proposal's pretty much written and they're just reading it and saying yes, that's okay. And then I think input from a lay co-lead or lived experience, or someone with lived experience, or lived experience co-applicants, it doesn't only strengthen the proposal, but it ensures that the outputs are, as I said, they really are reflective of what people need. And I think that's so important that, this is, the research really matters, and it's going to make a difference to patients or members of the public. And I suppose, put simply, John and I always say the combination of professional expertise and lived experience is greater than the sum of its parts. And I so think that is true. Lastly, I'd say one of the biggest learning points for me was the fact that when COVID delayed our submission date by 6 months for our, this was the phase 2 application, I was absolutely, I was so disappointed, really disappointed, because we've been building up to getting it in on that date. And actually, I never would have thought this at the time, but it was the best thing that could have happened, because that additional 6 months gave us so much more time to work and develop just a well-honed and much better and much improved application. So it was really, it was actually a great a great stroke of luck for us. I mean, yeah, that's all I can say. And I never would have guessed that. And so it really hit me, because I was so disappointed to begin with. And I think I'm going to stop there and let John go on now. John, talk to your points.
Yeah, and on the point of lived experience, they're writ through this whole thing. The co-applicant, professional lived experience co-leads of every work package. We have a lived advisory group who sit on the study steering committee. We're trying our best. We never get it right, do we? So we're always frustrated that it's not enough, it's not deep enough, but we are trying to get that right. One thing I wanted to, what occurs to me is the real impact. I think this was, some of the reviewers were very, very positive. And I think that one of the reasons for that is not that it was clever, but that it spoke authentically about the need and trying to address the problem. And I think one thing I've realized is that although all academics would like to have impact and policy and things like that, what Sarah wants is something much more tangible, something she can almost get hold of, not beyond policy documents or beyond future successful grant applications. So we're looking for the same thing, but you're driving this sort of real impact of it much more than would normally happen. And the final thing to say is about not being scared of using complex methods to solve complex problems. I didn't think the HSDR would fund it, I have to say, because it's not been tested so much before, but they did, and the reviewers were very positive about this. It does mean, as a chief investigator, that nobody on the study understands each part of it as an expert. So our job is to oversee a series of engineers, for instance, doing their bit, whilst we have to understand as best we can, guide and control and manage the process. But yeah. So I've put this up next to the slides I shared. You can contact us if you want to hear more about the project. We have a podcast which you can search, Mental Health and You. It's on Spotify. I've just found it. It's one of a series of podcasts that the department we've got. Or you can, there's information on the Trust website if you want to learn more about the study. And Sarah has a good interview, don't you? In fact, it's one on the it's one on the website, but you've got another interview you've done as well with the RDS, haven't you, Sarah? Which there's a link there for.
Yeah.
So that's all. Thank you very much.
John, that's terrific. And Sarah, thank you. Congratulations again for everything you represent, really. I think that's been a terrific summary illustration of what this morning is meant to be about, and it's come together. Yeah. You'd think we'd rehearsed all 3 hours of this morning to make it look so seamless, but that was absolutely terrific. And yeah, I recommend the interviews and the podcast. They're really inspiring, and certainly I found this whole morning inspiring. So there aren't questions popping up on the chat box or in the Q&A system. So I think I'm going to take that as a sign that this was all super clear. I feel like we've covered all of the main points that we needed to achieve this morning. And Sarah, thanks for your plug for the thing I started out at the beginning about using the Research Design Service team to support people applying, and you've illustrated how the team that I'm very proud to lead in the East of England can help. But because we've got people from across the country here, I'll just say, your local RDS is here standing ready and waiting to support you. And for the other speakers this morning, I know that Charlotte had to race on, but for Suzy and Claire, again, really super helpful presentations this morning, very inspiring. And hopefully everybody feels that they are now better equipped to put in an inspiring and change-making research bid that will make a difference to the health and wealth of our nation and meet the needs of our service users. So if that's okay, I don't have any other last words to add. We'll call that a wrap. But if anybody else does feel like there's something they should have said, do speak up now. I'll stop recording as well. Some people get shy about things that are recorded. Okay, yes. So thanks.